Okay, guys, this is a pretty quick one, just going through the different humidity devices that we are going to be talking about in Module 3. These are all put on that humidity grid that you guys are responsible for. The humidity grid that I made for you guys does have more detail about how the devices work, and some other kind of contraindications and things that'll kind of help you to hone in on when you would pick one versus another. So they're in two places. So I'll kind of explain this, and then you guys can look at that grid and start to make flashcards so you can start to differentiate which one you would pick. So really quick to circle back to our previous lecture about humidity, the primary indications for humidity, you have two that you're looking at. One is to humidify dry medical gases with the goal of room humidity. So when you're thinking about that, you're really thinking about your nasal cannula of greater than 4 liters per minute. And when you're talking about room humidity, you're talking about essentially you're getting that medical gas just to the same level of humidity as the surrounding environment. Okay. And then after that, you're really relying on the nose and the mouth and the natural mechanisms that your body has to humidify that the rest of the way before the air reaches the lungs. The second primary indication is to humidify dry medical gases to body humidity. And that is different. That is when you're talking about bypassing the upper airway. And there's a couple ways that we bypass the upper airway. You could have an endotracheal tube, a tracheostomy tube, or when you're on high flow, you are essentially bypassing the upper airway, because when you get to these flows that are around 40 liters or higher, it's moving so fast past the nose and mouth that it doesn't have enough contact time to really get the humidity that it needs before it goes into your lungs. And we care about the humidity being there when you're talking about those high flows or when you're talking about bypassing the upper airway, because if you're sending in dry medical gas into the lungs and you're creating a large body humidity deficit, we get concerned about the damage that's going to do to your lungs. And we talked about that a lot in the previous lecture. So just kind of really remembering that when you take a breath in, when you're breathing, when the air that you breathe in gets to about 5 centimeters below your carina, that's called your isothermic saturation boundary, then that gas should be 100% relative humidity. It should have 44 milligrams per liter of water vapor content. It should have 47 millimeters of mercury pressure for the water. And that's what you expect to see under normal conditions. When we are bypassing the upper airway, we are responsible for creating that for the patient. We need heat and we need humidity. So the goal is to at least have 30 milligrams per liter of output if you're bypassing the upper airway. That's kind of the magic number. Obviously, if you can get it higher, that's better, because then you're eliminating even more of that body humidity deficit. But the minimum goal that you should have is the 30 milligrams per liter. So the humidifiers that we're going to be looking for body humidity is we're going to talk about the HME, which delivers about 30 milligrams per liter, that magic number. Or we're going to talk about heated Passover humidifiers, and they deliver a little bit more. They deliver between 30 and 44 milligrams per liter. Our secondary indications of humidification are more about secretion mobilization. So we have nebulizers, which we talked about. You have the large volume jet neb. Again, you guys, I'm not going to make you memorize these outputs, the HME, the Passover. The only output that I really want you guys to know, besides the body temperature, pressure, saturation boundary, is I want you guys to know that if you are bypassing the upper airway, that you want the minimum output of at least 30 milligrams per liter. You do not need to know these other outputs. You don't have to put them on a flashcard. I'm not going to test you on them. So for the large volume jet neb, you have 35 to 55 milligrams per liter. You can actually heat a large volume jet neb. So they can be used for tracheostomies, and they can be used for a high flow where your upper airway is being bypassed. And we'll kind of show you how to do that in lab. This is that ultrasonic nebulizer. It snuck onto this guy and didn't get deleted, so you can just cross that one out in your mind. The high flow nasal cannula, I just want to throw this out there. If you are going to put somebody on a blender for secretion mobilization, and that's why you're putting them on there, because you're treating this secondary indication, the high flow nasal cannula is not great for secretion mobilization. Just when you think about the fact that it's throwing flow through the nose only, and it just doesn't have as much surface area as a mask. So if you're really looking to get secretions moving, and that's really why you're doing the blender, you would probably do a mask. That being said, if you're looking strictly for like FiO2 needs and you just want it to be humidified because you're bypassing, but they don't have a ton of retained secretions, a high flow nasal cannula is more than suitable. Another reason that you would do humidification, if not for the first two reasons, is upper airway edema or bronchospasm. So that's more the cool, bland aerosol provided with a large volume jet neb. Again, if you think about swelling, if you have that cool air hitting it, it's going to help to vasoconstrict those vessels and get rid of some of that swelling. And then treatment of hypothermia. So we will use the heated passover heaters at body temperature, pressure, saturation. So you're looking for that, setting it essentially between those temperature ranges, looking for that humidity output, and then it helps to warm patients if their core temp is colder. So that's a secondary indication that we can use it for. The different devices and how they work. So the bubbler for the nasal cannula, you can change, and I would throw on all of these, change per hospital protocol, because some hospitals might have a protocol in place that's different than the manufacturer protocol, but change per protocol. For the bubbler, we change them when they're empty. It works through, basically, you hook it up to your flow meter, the gas flows down the column, and as it flows down the column, it bubbles up through the water. When it hits the surface of that water, it pops those bubbles and it releases molecular water basically into the gap there, or the air, and then that gets picked up by the gas that's delivered back to the patient. There's a lot of debate about how effective these are as humidity devices, but either way, if they're on 4 liters or more, we put them on a bubbler. And this is going to humidify to that room air humidity, not to body humidity. The large volume jet neb, which I'm just going to remind you guys is the Bernoulli principle, or that Venturi system, it's filled with sterile water, and then we change that every 24 hours. And the reason why is the large volume jet neb is not delivering molecular water, it's delivering particulate water. And that matters because when you are aerosolizing your humidity, like you do with a large volume jet neb, you have the capability of transferring pathogens 2 ways. One, the droplet sizes are bigger than molecular water, so they can carry bacteria, viruses, things like that. The other reason is because the large volume jet neb acts by entraining room air, it can bring in pathogens from the surrounding environment that make it more adept to infection. So those are changed every 24 hours, whether they're empty or not, they get changed. There's 2 passover heaters that we're going to learn about. This is your active heated humidity. You guys can look at the grid for more detail, but the reason I say the name says it all is essentially it's designed to take the flow from the device, pass it over water in either a wick or a simple reservoir, and you guys will see the difference in lab. It's kind of hard to explain before you guys have hands-on. And then essentially that air is going to pick up the humidity from those 2 devices, and then it's going to go from the heater to your patient. Those we change if they malfunction, which does happen, or if they're visibly soiled. The next thing we're going to talk about is the HME, and that's short for heat and moisture exchanger. And there's a couple examples of those we're going to see in lab, but essentially what it is, it's a device, a small device that sits in line with your vent or on a trach, and it recycles your own exhaled air. So when you think about, I always try to think of the comparison of if you ever have put a scarf over your nose and your mouth in the wintertime and you're breathing out into that scarf and you don't pull it down, it collects moisture and it starts to get damp, and then also like it can help to keep the air that you're breathing warm and humidified. The HME works very similar to that. It's got almost like a sponge-like looking material. It's going to collect your exhaled air. It's going to trap that moisture. It's going to trap that heat. And so then when you're breathing back in, it uses that to heat and humidify that air back to you. These we use for our short-term vent patients that don't have any contraindications, which we're going to talk about some of those a little bit later. And these we would change per hospital protocol or if they're visibly soiled. So contraindications of an HME are heat and moisture exchanger. You cannot use an HME if the body temperature is less than 32 degrees Celsius. The reason why is if you are hypothermic and you do not have a normal core temperature, when you exhale that air, it's not going to have an appropriate amount of heat, right? So it's not going to be able to recycle and give your heat back to you. The other thing is we know that temperature has the greatest influence on humidity. So if you have a colder core temperature, your ability to humidify is going to be compromised already because cold air does not hold as much moisture, okay? So that's two reasons why if your core temp is lower than 32 degrees Celsius, you cannot use an HME. So if there's any mention in a patient case scenario of hypothermia, just know that it has to be that active heat and humidity, which is your Passover humidifiers. If you have copious amounts of secretions, we are not going to use an HME. And the big reason for that is the HME only does about 30 milligrams per liter of output. It's not nearly as effective as heated humidity. The other reason that we don't like HMEs if you have copious amounts of secretion is it sits in line with your vent or with your trach. And if you think about the propensity to cough up thick secretions, they're all going to sit there and fill that HME and block that HME. So it will essentially malfunction. It will get either filled with secretions and be ineffective, will get blocked by secretions and become ineffective. So if they have a lot of secretions, we don't use an HME. If you have a large airway leak, so there's circumstances where potentially you have a large leak. If that's the case, you can't use an HME because, again, it would not be able to trap your recycled air because you'd be leaking air somewhere else. That one doesn't come up very often, but if ever it did, that would be a reason you couldn't use it. If you have a very large minute volume, so if you have a patient that's very tachypnic or taking very, very deep breaths or a combination thereof, HMEs are not great devices for them because when they exhale, it's not really enough contact time for them to really get enough humidity and heat into that device that it can recycle it properly. So when you're thinking about those patients that are really breathing very fast or breathing very large tidal volumes, HME is not the greatest. And then if they're intubated longer than 5 days, when you start to have these longer periods of intubation, you start to require a little bit of extra help with that heat and humidity because ultimately it's not a natural thing. It's not physiologically normal to have your upper airway bypassed for that long. So we want to just make sure that we're providing a higher level of humidity output just to prevent any damage to the lungs. Some of the troubleshooting associated with the different humidifiers. A big thing is tubing condensation. You guys are going to hear it referred to as rainout, okay? And what that is if you have a heater that is at one end of a device and then it's going up into your patient through either vent lines or blender lines or a large volume jet neb with tubing. Either way, there's a distance from the actual heater to your patient that air has to travel. And even with heated lines which have temperature probes to try to keep the temperature from the heater to the patient essentially the same, there's usually some variability there. And usually the variability occurs in the sense that it starts off warmer at the heater and cools down slightly as it gets towards the patient. Well, if you know that temperature has the greatest influence on humidity and the air's ability to hold moisture, if you think about what that means, as the air leaves the humidifier and travels to the patient, it's going to cool down slightly. As it cools down, it's going to rain out some of that humidity because it's going to lose its capacity to hold it because it's cooling down. So one of the things that we have to do as RTs is check for the amount of rain out. You want there to be visible condensation in the tubing, because that's how you know that that's adequately humidifying the air to the patient. But when it starts to get like gloshy, where you are actually having lots of water in the tubing, you have to really think about if there's a problem, if it's malfunctioning, if maybe you need new temperature probes. It also is pretty gross to have a lot of water just stagnant and sitting in tubing, because it's going to collect all kinds of things that you don't want it to collect. So when you notice that there's rain out in your tubing, you have to be very careful about making sure that you're draining it out away from your patient. Kind of a circumstance that I feel like comes up a lot with trachs and ventilated patients is, they are usually sedated when they're ventilated. Or for trachs, they don't obviously have to be ventilated, and this can still happen. But if there's condensation in the tubing and they get turned or boosted or moved, and someone doesn't check the line before they do that, sometimes that condensation that's been sitting there can get dumped into their tracheostomy or dumped into their end tidal or ET tube. And that is a problem for a couple reasons. One, it's an aspiration. You never want to aspirate anything. But this is fluid that's potentially been sitting in a line, so you don't want to create an infection issue there. So just making sure that you're watching your lines, draining your lines. The other reason that we care about condensation in tubing is if they happen to be on a large volume jet neb. We looked at those in Module 1, and they are a Venturi system. So they have that disc adapter where they screw onto your flow meter. And then for that one, it just has a variable air entrainment port. So if you're on 100%, that air entrainment port is going to be closed. If you're on the lower percentages, where you're about 30%, you're going to have large air entrainment ports. If you have condensation in your tubing, to the point where there's a decent amount of water in there, what will happen is it will create like a back pressure or a resistance, and it makes it so those air entrainment ports are not able to entrain the air very effectively, because it almost acts as like a blocking, because that back pressure from the water gloshing in the tubes makes it so that the device cannot basically operate and pull in room air. If you have a large volume jet neb that cannot pull in room air like it's supposed to, then it's going to rely on just the oxygen flow meter. And we know that if it's hooked up to a flow meter off the wall, that's delivering 100% oxygen, and it gets diluted by its ability to entrain room air. So if you have a lot of condensation there, it can't entrain that room air like it's supposed to. It's not going to be diluting down that oxygen. So then you end up with a higher FiO2 than what's actually set. And we'll see this in lab. We'll do some examples where you guys will analyze, and we'll actually fill the tubing with water, and you guys will see that FiO2 climb. But that's something that we also need to be aware of. So those are kind of the troubleshooting, and really tubing condensation, I feel like, is a big part of that. Really, that's it for this one, guys. And I might go through the grid and give you guys a synopsis of that so you guys can see it in more detail. But just definitely make sure you know that you're responsible for all of those humidity devices, and knowing the different classifications for them and when you would choose one versus another. And I have some practice up already for you guys to kind of start like troubleshooting that out and seeing if you can figure it out.